Hello, my name is David Villar, professor of pharmacology at Colombian Veterinary School. Welcome to this video on which we are going to review some basic guidelines for the treatment of urinary tract diseases in dogs and cats. I just wanted to remind you that AVMA in 2015 put together a task force on antimicrobial stewardship in companion animal practice to basically provide some guidance on in light of the emerging impact of multi-drug resistant organisms which are appearing. And as you can see here, they developed some do's and don'ts on antimicrobial prescribing. For the case of a urinary tract disease, they recommend to avoid diagnosing infection based on a free catch of urine samples and to always confirm infection with quantitative cultures, as we will see later. So, if in the previous video we said that superficial skin infections accounted for the largest reason for overuse of antimicrobials in dogs, I guess with urinary tract infections, we could say that that's another reason where we certainly misuse and we definitely overuse them also because there have been no clear guidelines for neither diagnosing or and treatment of many of these conditions. So there are a couple of documents that have been put together by the working group of the International Society for Companion Animal on Infectious Diseases on this matter. We're going to see what their recommendations are on this presentation. The first document was launched in 2011, and there has been many changes made ever since on the latest version on 2019, and we're going to point out some of those major changes. As with everything in medicine, they base recommendations on a diagnosis, and they divide the infections into four major groups. A quick summary table that can obviously not be applied to all the time for all the conditions, as we would commit many pitfalls, is the ones that we have here. You do not want to treat empirically these days, even if it is the first time that you see an animal. As you can see, subclinical bacteriuria does not require treatment, antimicrobial treatment. So that's one of the conditions that we may have been overusing them, just like when we catheterize animals, in which we are definitely prompting them to develop resistant bacteria if we need to treat those animals later on. So anyway, here are the four major groups that we're going to see one by one, and we're going to describe what the working group suggests for each one of those conditions. So the first one is the typical sporadic bacterial infection of the bladder in an otherwise healthy animal, which is not secondary to another disease or comorbidity. You reach a diagnosis by doing a complete urinalysis, which should be the minimum database for evaluation of any suspected urinary tract infection. And ideally, you want to collect sample by cystocentesis. But if you have the animal obviously catheterized, you don't need to do that. You should avoid doing a free catch because it can be easily contaminated and provide a false positive with many counts that are not reliable. Susceptibility is important, and you should be done according to accepted standards, so they can be interpreted and the breakpoints established for which specific drugs can be used. If you grow more than 10,000 colonies per mil of urine, that's usually becomes relevant, but only if there are clinical signs. Otherwise, those it may indicate you that you have a subclinical infection that does not warrant to be treated. So those clinical signs are usually dysuria, pollakiuria, painful urination, urgency to urinate. There might be some bloody in that urine. The animal may vocalize. So those are typical signs that something is going wrong. As you can see, one of the empirical treatments that can be usually used as a first line choice, usually amoxicillin, clavulanic acid, or trimethoprim sulfa drug. Obviously, if you have a sensitivity test, you can reevaluate whether that empirical treatment continues to be appropriate or not. And so the new addition to the guidelines of instead of that 7 to 14 days, they suggest a shorter course of 3 to 5 days. And there are two studies in which the outcomes were clinical and microbiological cure. And it was found that the short term, that is 4 days, is probably just as good as the long term, which was the traditional therapy. Ideally, the aim is now to decrease the bacterial load to a level that allows clinical signs of the infection to be controlled, while at the same time the patient's immune system is eradicating the remaining bacterial organisms from the tissues, in this case the bacterial and the urethra. So as you can see on this table here, they are comparing trimethoprim sulfamethoxazole at 50 milligrams per kilogram orally twice a day for 3 days, with cefalexin for 10 days. And on the other study, they were comparing enrofloxacin every 24 hours for 3 days, with amoxicillin clavulanic acid twice a day for 14 days. And they say that both protocols were just as effective clinically and microbiologically. So I guess the latest on this issue is that the short duration action is just as good as the long duration action. With regards to the complicated urinary tract infections, this tends to happen when there is an anatomic or functional abnormality or comorbidity which predisposes the patients to have a persistent infection, a recurrent or a treatment failure. So as you can imagine, identifying and managing the relevant risk factor is critical for the long-term success of the complicated urinary tract infection. We need to find that underlying problem and solve it, or it will definitely undermine the treatment of the underlying of the urinary tract infection. The other thing is that if we have treated this dog previously with any antimicrobial, we probably want to use a different one this time. For example, if we have used amoxicillin, we probably want to switch to trimethoprim sulfa drug. Another thing that has changed is that they no longer recommend treatment for 4 weeks. Now it should be reassessed based on culture results. So if it is a recurrent cystitis, in other words, a reinfection after a successful treatment, what they suggest is a short course of 3 to 5 days duration. So basically, when there is a relapse, which is a failure to have eliminated the previous pathogen, and they tend to occur within weeks as opposed to months for the reinfections, then they suggest a longer course of 7 to 14 days therapy. The one thing that is crucial for being successful, as I say, is controlling the underlying causes, whether it's a poorly managed diabetes or an allergy with corticosteroids or a hypothyroidism or some other type of endocrinopathy or what have you. And finally, once we have achieved clinical and microbiological cure, which is usually considered successful after 5 to 7 days of cessation of antimicrobial, There is always the question of whether it can be prevented because recurrence is very high. In humans, they recommend cranberry juice, and there are various other alternative therapies, but unfortunately, at the moment, there are really no good studies that to say what can be done in terms of prophylaxis in dogs. The other category is subclinical bacteriuria, and as it names indicates, is the presence of bacteria in the urine determined by a positive bacterial culture. That is not when we see bacteria by cytology. In the absence of clinical signs of urinary tract infections. In other words, you can have bacteria in the urine, but the animal is asymptomatic. Um, Other findings in the analysis, even if you have white blood cells, that may be predictive that there could be bacteria, but as I say. So the reason is that there are many healthy dogs out there, as you can see, between 2 and 12%. It varies depending on the study that can have subclinical bacteria, and those values may go up in certain groups, like those that have diabetes, obesity, those that are given drugs like glucosteroids, or have some other comorbidities. And because there is no clear association between subclinical bacteria and future risk of developing cystitis, at least in humans, there is a systematic review which concluded that you may eliminate the bacteria by treating with antimicrobials in the short term, but that effect is not going to be sustained because there will be a recolonization when you suspend the treatment. And if those individuals have a future urinary tract infection, they will have higher rates of resistant bacteria. And there is also anecdotal evidence that even if you have multi-drug resistant bacteria, it will not affect whether you treat or not. In fact, if you withhold the treatment, they will sometimes be replaced with susceptible organisms. And if those animals subsequently develop a cystitis, then the drugs will work. So the other common situations that results in bacteria in the urine is when you catheterize an animal. And as you can see, between 10 and 15%, 10 and 55% of the studies, depending on which one you look at, will have bacteria. And here the important thing is whether it's a real cystitis that requires treatment or a subclinical bacteriuria. In other words, whether you have the picture on the left or the picture on the right that you have to treat. And as you can see, the recommendation here is that prophylactic antimicrobials should not be given in the absence of clinical evidence of cystitis or pyelonephritis, obviously. So the last condition is, and obviously the worst, is for which obviously you want to start giving antimicrobials right away, is pyelonephritis. This is an infection of the renal parenchyma itself. It is usually an ascending infection, although it can come from the bloodstream also. As you can imagine, it's a very serious condition compared to a cystitis because it may cause a very rapid kidney injury and sepsis, which can kill the animal. And obviously, a quick diagnosis is very important. So is the treatment. And the diagnosis could be quite challenging sometimes. It's obviously going to be based on a positive culture and signs of a severe systemic infection. And as you can imagine, the treatment should be initiated immediately while at the same time you await culture and susceptibility testing. So the first line choices are usually the fluoroquinolones or one of the cephalosporins that you have here. They don't recommend that the duration of treatment be as long as it used to be. In this case, instead of 4 to 6 weeks, they make it 10 to 14 days, just like they do for humans. And just to wrap up everything, I have included a study here. Historically, a population of dogs with the three main categories of urinary tract disease, how the use of antimicrobials was associated with resistance. And as you can see, they had a population of 1,028 cases of urinary tract disease, and they were classified as uncomplicated, complicated, and pyelonephritis. And as you can see, they provided a table for dogs with complicated urinary tract disease with comorbidities that were identified at the time of diagnosis. Most of these dogs were referred from a primary care veterinarian, and they were diagnosed as recurrent urinary tract infections. They were obviously dogs that were also undergoing treatment for many of the conditions that are reported here. As you can see, the most common one was immunosuppression, which was probably treatment with corticosteroids or some other chemotherapy agents. The second one was kidney disease, probably either acute or chronic. And as you can see, there was some endocrinopathies, hyperadrenocorticism, diabetes, and so on. So if we look at the results from this study, the one thing important was that the dogs with a complicated urinary tract infection in general had more isolates that were resistant to a wide range of antimicrobials than the uncomplicated urinary tract infection. And not by a great margin, though, but if you look maybe just between 2% for amikacin, all the way up to 13.4% for enrofloxacin. But that already tells you that animals with complicated urinary tract infections may have been recurrent or been treated previously with some kind of antimicrobial. Another important finding that is not showing here is that the proportion of isolates that were multi-drug resistant was very high, about 31%. And of those, 79 were Staphylococcus, and 30% were enteric species. And again, the proportion of multi-drug resistant isolates were much higher for complicated urinary tract infections, 39, compared with the dogs that had uncomplicated infections, only 21%. The other important result from this study was that dogs that received amoxicillin, doxycycline, or enrofloxacin 30 days before the urine was obtained for doing bacterial cultures had higher resistant levels. And as you can see here, they're comparing those in column A, which are the percent of isolates that were susceptible to the designated antimicrobials for dogs being administered that antimicrobial within 30 days before culture. They're comparing those to the dogs that had not received any antimicrobials within 30 days before culturing. So if you compare the two columns, the values are strikingly differently. 40 to 60 for amoxicillin, 40 to 72 for doxycycline, 28 to 77 for enrofloxacin. So the conclusions from this study and that we can apply to our routine practice are that if we have previously given any antimicrobial at least 30 days of collecting the urine sample for doing a bacterial culture, the chances are that whatever isolates we get are likely to be more resistant not only to that type of antimicrobial, but to other antimicrobials also. What I found most relevant in this study is that none of the bacterial isolates achieve a susceptibility rate of more than 90% to any antimicrobial. In other words, out of 100 isolates, there are always going to be 10 that are always going to be resistant to whatever antimicrobial you decide to choose as a treatment option, even if you have never given that antimicrobial to that dog previously, which is what they found in the uncomplicated urinary tract infections. So as you can imagine, the fact that no one antimicrobial will kill all the pathogens in the population, combined with the great percentage, 33%, of multi-drug resistant isolates, is more than enough grounds or justification beyond any reasonable doubt, as any lawyer would say, to do at least a sensitivity test, even if it is the first time a dog walks into your clinic, regardless of what his history might be. And I think the final conclusion that we should gather from this paper is that previously prescribed antimicrobials may obviously affect the empirical choices in this situation. Doing susceptibility tests becomes even more important. Although, as I say, or I just mentioned, with such a large percentage of bacteria that are nowadays resistant to everything, it probably pays off to be on the safe side and start by doing sensitivity tests from the very beginning. So I hope all this information was worth listening to. I hope you learned something. I have learned a lot from reading these papers, and I look forward to stay tuned and hopefully get this message across and be able to provide more videos to you guys. So take care and see you on future videos. Bye bye.